Great, thanks. So, thanks for the introduction, Dirk. And so I'm Wes Williams. I'm a licensed psychologist, but it's been 10 years since I've shifted my work into health information technology. And I am currently serving as the Vice President and Chief Information Officer at the Mental Health Center of Denver. So the Mental Health Center of Denver is a private, nonprofit healthcare organization that treats behavioral health problems for the people in the city and county of Denver in Colorado. We have a number of clinics throughout the city, sort of a big adult treatment facility that's pictured here, as well as a couple of child and family practices, some residential facilities. We have folks who are treated in the schools. We have community-based programs where folks go out and work with the homeless population and connect folks that we're treating to other healthcare providers like primary care and specialty care, make sure that folks are housed, work on education and employment, right? So it's a comprehensive set of services, not a traditional outpatient or ambulatory kind of environment. And we deal with, at the Mental Health Center of Denver, a fairly complex and high-risk population, right? A lot of the folks that we serve are supported by either public funding like Medicaid or the state general fund pays for us to treat folks who are indigent, who have no other funding sources to deliver their care. Some of those folks are very ill, and when we do the treatment, sometimes the care that we deliver needs to be in an involuntary setting. So we do work with folks who are hospitalized, right? And we work to bring them back out into the community. And so part of this story comes from an unfortunate case that happened to us back a few years, where someone who was discharged from the state hospital into our care ended up shooting a 7-Eleven clerk and killing him, right? This was someone that we had worked with in the past, and we then stopped working with them while they were hospitalized, and then they came back out into our care, and we had a case manager assigned and a psychiatrist, and we asked the general sort of risk kind of questions, like, is there, are you having thoughts of hurting anyone or hurting yourself? Are you, do you have any weapons or anything? But the answers that this person gave at that time were sort of consistent with what you would expect for someone who would want to be out and about in the community, right? And yet it happened, and in fact he did have a gun. He did use that gun to shoot this clerk, and we as an organization, were unable to prevent that. And so that is tragic, and in this case it led to a $6 million verdict in a civil suit against our mental health center, right? And so you can imagine how many people we would need to serve to bring in $6 million into the organization. And the risk profile for that is not pretty, right? When we look at who we're currently serving, we see that almost 50% of the folks that we treat are currently at some elevated risk to being a danger to self or being a danger to other folks, with 19% of the folks being in that sort of both category, where they have both had some experiences where they, which puts them at elevated risk for suicide, and some which puts them at elevated risk for violence to other folks, right? And so we put together an initiative around, like, how do we manage this risk, right? And so we convened a clinical committee that had folks like myself from the health IT side, working with our chief medical officer, our director of risk management, a forensic psychiatrist, around, like, what do we know about dangerousness that we can sort of put into practice, right? What can we, how, you know, and so the first step in that process for us was going through our electronic health record and finding any sort of structured data elements that would, you know, load onto this risk of dangerousness. And so, you know, we went through every survey or questionnaire and found sort of critical elements, and the first pass was really which items do we believe, you know, would be a risk, you know, just from in terms of face validity, right? Like if someone had been convicted of a violent offense, right? We think like, oh, well, that puts you at risk for doing that again, right? And it doesn't matter, it's not a matter of sort of propensity scores or anything like that. It just seems to be fundamentally true. And so we went through and categorized everyone that we had in the population there and came up with this set of numbers which is, you know, we currently treat at any given time 10,000 folks, and like 4,800 of them are at some sort of elevated risk. And yet, the incident rate for adverse events is actually pretty low, right? It's pretty low, but it's pretty bad when it happens, and it can be very bad. So we started to think then about what are sort of dynamic risk factors, what are things that might shift in the course of treatment that would make the risk of something happening soon more sort of proximal. And we came up with sort of a list, and this is where the clinical input came in, where a list of different factors that we thought might be relevant, and we came up again with a structured form. So anyone in this sort of high risk category, we had clinicians fill out at least monthly, but whenever they had relevant information, a questionnaire around each of these dynamic risk factors. And the dynamic risk factors included things like arrests or suicide attempts that very obviously load on sort of this construct of harm reduction, as well as sort of acute stressors, things like lost my job or broke up with a relationship that we don't necessarily think would have anything to do with violence in and of itself, but someone who was sort of at risk for violence, this might be the incident that would push that person over the edge, right? And so we came up with that system of tracking, again with structured data, these dynamic risk factors, and we built in some triggers, right? So that when someone comes in and fills out this form, there's a set of responses that actually alert the care team immediately that these things are true, so that they can use their, at this point, clinical judgment to address, you know, the situation and what's going on. And we've been doing this now for a couple of years, and it's generally been a success, right? The clinical case managers feel like, I'm carrying this scary knowledge in my head, and now I have a place to record it, and I have a place to record it where I know when I record it, the rest of the care team will be alerted, right? So that's been pretty good. And there was a component for us that thought, like, maybe we should stop there, stop while we're ahead, right? And yet we're still managing all this risk, and there's this promise for more, right? And the promise is that in psychiatry in particular, quite a bit of the clinical information that is stored in the record is stored in unstructured data, right? I mean, we built out our EHR. It has sort of checkboxes on the risk assessment, but then there's actually quite a bit of narrative information. And when the psychiatrists deliver their sessions or the case managers go about and do their case notes, it's largely big text blocks of data that they're entering. Here's what's going on with this person. And there's a richness there that I think we didn't want to ignore. And so we use electronic health record called Avatar. It's delivered by NetSmart, which partners with InterSystems to, you know, it's built on the Cache backend. And so NetSmart came to us and said, we have this opportunity working with InterSystems to use a technology called iKnow to mine the unstructured data within your system and start start indexing it and give you a little bit more insight into what's going on. And so we started having these conversations around how can these two projects map together, this iKnow unstructured data and this issue of tracking risk and harm in the electronic health record. So I'm going to turn it over to Dirk here, and he's going to talk a little bit about the technology, and then I'll come back and talk a little bit about what we're doing with that.
Thanks, Wes. So, and I will start with a little bit background and maybe a little bit theory. And I know it's at the beginning of the morning, so hope everyone is awake to listen to this background. And if we talk about NLP and text analytics, then you see, let's say, two different ways. So the very classical way to do text analytics is what we call really top-down. And what we mean with the top-down approach, people building dictionaries, ontologies, so formal structures, and from these formal structures on, they try to fish and to find the word and the word groups that are in text. So in a certain way, very predefined. And what we find as a very important way of using text analytics is really starting from the data itself. And that's really our iKnow approach. So without knowing what's in a certain domain, we can identify all the meaningful word groups and the interrelationships between these meaningful word groups. And especially in healthcare and life science, it's really important to recognize meaningful word groups that are 4, 5, 6 words long.
We may have other databases.
I don't think it's kind of certain auditive hallucination that we hear all, but so we're on safe hands. So I didn't prepare that part. So again, it's really important to grasp all these meaningful word groups. They are quite long. For instance, if there's something mentioned about dopamine, then it's really about the substance dopamine. But if there's something mentioned in the text about dopamine receptor gene, then it's something totally different. So again, it's important to have this meaningful word groups without predefined knowledge. And this top-down versus bottom-up approach is not only from a technical perspective really important. And that's also what I think we can see here with this project in Denver. Because top-down, that's also the way that clinicians try to improve healthcare. For instance, by building guidelines, having clinical protocols. And mostly they are doing this by putting a group of experts together. And these experts write down a very nice protocol, and then go to the clinical practice and say, okay, now you have to use this clinical protocol. And there is a really disconnection between these formal structures, everything is in mind of experts, and the real clinical work. In a certain way, that is also the work you have done before. So by thinking, okay, what could be all these risk factors, having a certain idea, but now let's see how this is expressed in your huge data set. And for instance, here I give you also an example versus the top-down versus the bottom-up approach. And as a psychiatrist, I'm always very interested in bipolar disorder. So if you do, for instance, some research about bipolar disorder, and like every clinician or research, you have some ideas, some concepts in your head. And so that's on the right side. While, for instance, by analyzing your data, you could immediately see, okay, these are the concepts, and you see also the frequency of this concept that are in that specific data set. So it's really data-driven. And we are not only interested in concepts, but we are also interested in concept relation, concept patterns. So what are the things that are combined with each other? And for instance, again, here with the example of bipolar disorder, you could immediately see what are other concepts that are connected with bipolar disorder. And that is really helpful. For instance, also if you want to look for adverse events or adverse drug effects, or for instance, what happens after suicide, you could immediately see what is in the neighborhood of this concept. And that's totally different in quite a lot of approaches that try to use, for instance, machine learning algorithms and so on, based on single words, what we call bag of words. So we all dream about building clinical decision support systems and doing analytics. And the way we approach this is say, okay, that's fine, that's our end goal, predicting patients at risk, but let's try do it in several steps and make sure that each step as such has already his own value. And the way we split this kind of project in different steps is, as you can see here, the first step is when you have such a huge data set that we give the clinicians, the researchers, the possibility to navigate through this electronic health record system and to really see what's in their data. Because if you start doing this kind of things at the hospital, everyone is very proud to say, oh, we have huge amounts of data. We have 10, 15 years of data. We have even million clinical of notes. And then I think I refer also to the VA in this case. But no one knows exactly what's in that data set. Everyone can count single words, but no one has a certain idea of that. And that is what we can support with this intelligent navigation and exploration part. A second use case or a second step in this process is try to identify certain cohorts, certain patient cohorts, certain groups. For instance, also this patient at risk, we have a certain model in mind. We know already, for instance, that the word gun and suicide, that is important. So let's see in that data set what are the patients that are having this criteria. And then very important next step is the data-driven model. So not thinking, okay, this is what we have in our head, but just see what's in the data, what's coming out from there on, and based on that, moving to a next step and building predictive models. And then using, for instance, statistical programs, machine learning techniques, and that kind of things to build a model. And once you have that model, also use that model for new incoming data. So again, that's in a nutshell a little bit background on how we approach this kind of projects.
So one of the important ideas that Dirk touched on right there that is really relevant for this project is making sure that each step is valuable in and of itself, right? That realistically, we're a community mental health center. Right? We don't have resources to solve the fundamental problem of, like, can we stop, gun violence and danger, suicide, right? These are broad societal problems, but they're ones that we've wrestled with for a number of years, and that we think, fundamentally we do a pretty good job of on the treatment end. And so how can we leverage this technology to sort of help with that concept? And so we've turned to this notion of Agile to make sure that we're delivering vertical stories, right? And so this is sort of the illustration I give to my team around, making sure that you're not just working on the database layer, right, or the business rule layer, and not delivering something that may ever see the light of day, but making sure instead that each step along the way we deliver something that can be put into clinical practice, right? Put in, and used, and it's not the whole problem, right? Like, and I don't know that we'll ever get to the whole problem, and that's one of the compelling pieces of that, is that fundamentally with Agile, at the end of the day, you may just have a delicious slice of cake, and that was yummy, right? And so the first slice of cake that we're looking at is this notion of electronic health record navigation, right? So we've dumped our clinical notes into this database and index them, and now we can search for a concept like gun, and it'll pop up, and here are the actual records that have that, and the search term can be highlighted, right, and pop out really visually, and it makes for a really fast way to review the record. It's right now, and we've been on an electronic health record for 13 years, right? It was 2003 that as an organization we started going electronic, right? And for that 13 years, the EHR fundamentally has been a really well-indexed paper chart, right? When you get into the clinical notes, you still have to read every note in order to find, is this concept there? And there is this notion where our chief executive officer is a practicing psychiatrist, right? And he was treating someone who had a history of substance abuse, like methamphetamines and cocaine, and yet this woman said, you know, I used to do really well on Adderall, but no one will prescribe it to me. No one will prescribe it because it's a stimulant and it's subject to abuse, right? Dr. Clark went through and read through 12 years of chart notes to find, buried in the record, yes. In fact, she had a course of treatment over, you know, multiple years where she was very stable on Adderall, so he was willing to re-prescribe that. And so he did that effort, but it did involve reading every note and bringing something like this, which we're purposing here initially towards you know, this notion of harm reduction, could be repurposed for that. And that was one of the immediate insights when Dirk and Clint came out to Denver. We talked a little bit about, you know, what could this be like? And the clinical committee really had an aha moment of like, this would not just be good for this harm reduction initiative. This would be sort of broadly good to be able to do this work. It would be broadly good. You can search for medications and signs and symptoms. You can search for, you know, and so from clinical practice, it's useful. It could also be useful, you know, our quality improvement department would be like, this would be so much better for chart audits, right? This would be so much better to look at how we do training and how we can improve upon that. And so this is the sort of first slice that we are going to be delivering into the clinical practice, right? And for me, I hope we do not stop here, but if we did stop here, it would be much better than what we have right now, right? However, we are hoping to push forward, right? And to actually sort of manage this risk and to look at how these different constructs within the within this sort of overall framework of harm reduction map together, and what are sort of high-risk cohorts, right, where you may get, you know, that same framework that I talked about in terms of the dynamic risk factors assessment, how those actually manifest within the notes, and be able to map things like, you know, psychosis, and psychosis with, you know, threatening thoughts towards another specific person, and weapon possession and violence risk. Those things sort of map together, and I think, you know, we have some of that in structured data, but the reality is that a lot of that gets entered at intake and then not updated on a routine basis. And when new information surfaces, it's routinely going into the chart notes, into this unstructured information. And so a second sort of slice of the cake would be delivering and merging in the information that the psychiatrists and the case managers routinely collect into the sort of structured data set to be able to, you know, better and more finely predict who is sort of at risk, and do that risk stratification in a more nuanced manner than our two big circles in that early Venn diagram, right? The next step then is building sort of evidence-based modeling, and the important thing here is, you know, we have quite a bit of information and research around what constructs are important, but we don't actually know how clinicians are representing those constructs in the actual health record, right? And so we know that access to a weapon is important, but we don't actually know exactly how clinicians are routinely documenting weapons, right? I can pretty much assure you that they're not typing weapon into the chart note, right? They're being a little more specific about it. Was it a butcher knife, or was it a hunting knife, or was it a butter knife, or a plastic knife? And guess what? We're not worried about those, right? Or as much. So this is, I think, the power of this approach of taking the bottom-up thing and mapping it to our top-down framework, right? And so building out something that can, I think, be more accurate and comprehensive. And, you know, I have to say, when I first thought of this issue, I thought, there's no way we can deliver this because it's too big. But the beauty of this sort of agile approach is, you know what, just take a slice, do it, and you will, we can start with knives. We'll start with knives. Actually, we're going to start with guns because they're a little more lethal. But we're going to start with guns and think about how we frame that up: guns, firearms, pistols, revolvers, etc. And then the next step will be knives, and eventually we'll be done with weapons, right? And we'll be moving on to sort of suicidal intent and suicidal ideation and a plan and this whole clinical framework of what is it that we want to do to track, and how does it actually manifest itself in the clinical notes. And then we can tie that back, probably a bad sign to go backward in your presentation, but tie it back, and so you have these built-up dictionaries and highlight these terms in the note, and it'll fundamentally bubble back to the EHR navigation where the clinician is typing the stuff in, and different words are highlighted as they're sort of moving along. And that leads me, I think, to the sort of final idea here, which is ultimately we got into this because the vision was to be able to predict risk in real time, right? We would have this clinical understanding, and we have this body of knowledge. Some folks have been in treatment for quite some time and have many, many notes in the system, but the clinician may be new to them. And when I say case manager, I really mean a bachelor's level person out of college, usually in their first job, working for 2 or 3 years, going out and about into the community to work with folks who are homeless. Those are folks who don't probably have that 10-year history of the patient, and yet they're entering information that they learned today that's relevant to this. And so the vision is, can we, when that case manager is entering this information, say something has shifted now, and we think the care team needs to be notified. And I don't know if we're going to get there, right? I don't know if we'll get to that point, but by taking this agile approach, we will have guaranteed that we will have delivered something better than we have now at each step along the way, and we'll have also set ourselves up to really have much more power in using this sort of fundamental data science question of, can the results be delivered? And so that is sort of the framework that I wanted to introduce to you today. And so thanks, and I think I'm going to turn it over to Augie to talk a little bit about his work that he's doing, and then we can do questions at the end. So I actually have the slides up here. Thanks.
Hi, I'm Augie Tarano, and I work for the Department of Veterans Affairs. We have a lot of notes. We have a lot of unstructured data in the VA. And so this has always been a challenge. I'm the director of some analytic department in the VA, and researchers submit these requests to do different kind of analysis. And most times it's just structured data, but we get probably 40 or 50 proposals a week for studying everything from cirrhosis to cancer to PTSD. And a lot of the work that comes in, basically, it needs the unstructured data to really supplement it. We have so many departments in the VA, and so many people do reports that are text that we really can't ignore it. Anytime you have a procedure or an operation where there's a bad outcome, it's really important to be able to look at the unstructured data to try to find out what's wrong. And not only just find out what's wrong, but to be able to quantify it, like get the frequencies of the bad outcomes. So normally when we do a study like this in the VA, we'll pull a patient cohort like Wes was describing. And then once you have this corpus of documents, we'll pull the notes for whatever seems like the appropriate number of years. And then what I do is release it to iKnow and get the concepts extracted and things like that. Then it's a simple matter of going through and matching up the bad outcomes and seeing, well, how many, as search terms, how many did we find? So our EMR in the VA is getting really dated. I mean, I used to be really proud, like in the 80s and 90s, because we had this integrated electronic record, and it was really good. But probably for the last 10 years, not a lot has happened. right? And it's kind of lagging behind. The doctors who have the biggest complaints basically are telling me that it takes us so long to find stuff in the EMR. I mean, all you guys in here are, you know, professionals and probably work with medical data or other data. And they can't find what they're looking for. So they got a patient sitting in the exam room and they really, like Wes was describing, they need to find something in the notes. Well, we have a lot of older patients in the VA, and so for some of these guys, there'll be 20, 30 years worth of notes. They only get bunches of 250 at a time, and then they gotta hit the return button, and it's really slow. So if you're only seeing a patient for 10 minutes, you cannot sit there and hit the return button. It can't happen. So with iKnow, we have the capability of doing a search, right? We can build a domain per patient or whatever and be able to pull up, you know, did the guy have thyroid cancer, or, you know, whatever they're looking for, and they'll be able to find it. And we can go back because iKnow tracks every document that it has. You could go back and say, okay, on this date we found this note, and you know, you can actually go back and drill down into exactly what happened. So there's a lot of things that you can do for looking at all kinds of QA different applications. So, and then the other thing too, since we have this integrated record, I can take data from our corporate data warehouse, which has all of the notes from 25 years, and open up an ODBC connection and pull the notes down really fast. If I want to get lab values, we have stored procedures to do that. I can also get the data directly from the Vista system. So, I mean, one of my jobs is to play with the technology, and you know, with Dirk and a bunch of InterSystems engineers, we've tested just about everything. We've taken data in from flat files, we've taken it from ODBC, we've run stored procedures, and all of those techniques work really well. You know, it really depends on where your source data is, which one of those mechanisms is the one that you want to use. But it's really just getting it into that iKnow engine that's really kind of the interesting thing for starting the analysis. So once you do that, you know, you're going to have this body of notes, and you know, as it was stated before, finding out the concepts and being able to do the extractions, finding relationships, that's all really important. So I'm going to go through some of these slides pretty fast, but once you pull the concepts out, there's a whole bunch of things you can do with it. You can map it to different terminologies, and with HealthShare and some of the other tools that are available, you can take things and pick what you want to map to. You can map to UMLS, SNOMED, ICD-9, ICD-10, you can do a lot of stuff. They have a nice GUI, but for the really large data sets, the GUI's not really very practical. I mean, sometimes I'll index 1 million notes or 5 million notes or 20 million notes all at once, and whenever you're doing that, the I/O back and forth to present a web page, sometimes it'll time out or do whatever. The interesting thing with doing that, I mean, I like to code, and they have a lot of it. Well, just about everything you can do with iKnow is available through an API. So I can construct with just a few simple calls a way to get similars or similars as you probably saw before. When doctors or nurses are typing notes in, they don't always spell things right. In fact, most of the times they spell things wrong. And so that's problematic when you're looking for, you know, a term, even something like pneumonia. It's amazing how many different variations there are. But with iKnow, you know, it will show all the similars. And I have some slides where I actually go through, and I'll show you some of this stuff. So these are things that we've done, you know, with iKnow inside the VA. You can build filters so that, you know, once you get a corpus of documents, you can say, oh, I only want female patients, I only want male patients, I only want patients from the state of Florida. Once the documents are in there, it's really easy to do. It's just drop down, pick the metadata. You've got the typical operators, you know, equals, greater than, and that kind of stuff. Stemming and a lot of the typical stuff that you'd find in NLP typical programs are in there too, right? So again, this is just more of the same. When I started doing the notes, I actually decided that I wasn't capable of really doing it without some help, right? As I looked at the notes, these doctors, and it depends on what department you're looking at, they've all got their own shorthands and abbreviations. And, you know, I'd see things in the notes like RO or HO, and, you know, I had to call on my clinician buddies to tell me what that stuff meant, like RO means rule out, HO means history of. But those same terms can mean a lot of stuff depending on what the notes are. So there is ambiguity with this, so you really need some experts when you're doing like really detailed analysis. So in the VA, you know, there's never one way to doing anything. So in competition with a lot of these other things, these are all tools that were available or are available in the VA. And each one kind of has its place. Like, you know, there's open source Lucene, Elasticsearch, SAS Text Miner, and, you know, each one has pluses and minuses. The thing that I really liked about iKnow was I didn't have to fool around building ontologies or mapping anything, whatever. You can pull it out of the box, give it a whole bunch of documents, and pretty much hit go, and you start getting concepts out of it. I did some of these other things the other way, and basically, you know, I'm a small team in the VA, like a team of one. And I had InterSystems helpers that, you know, really jettisoned me to being really productive. But I tried doing stuff the other way with typical NLP, and I knew immediately that, you know, building ontologies and terminologies and all that stuff was, number one, I was out of my domain, right, because I'm a computer guy, I'm not a medical doctor or whatever. And when I saw iKnow for the first time at one of the global summits, I guess it was a couple of years ago, when I found out I didn't have to know anything to be able to get stuff out of it, I'm like, that's the kind of stuff I like, right? When you know, the less you have to know to get something out of it, the better, right? So this met all those criteria. But, you know, and you saw some of this before from Wes. What I really liked about this stuff is I started doing some work with the renal teams in the VA, and they would give me these search terms or whatever, and without building any ontologies, you get all this stuff like renal ultrasounds, renal cell carcinoma, renal calculi, I mean, things that you'd never really look for. And to me, you know, it's just like, this is the equivalent of n-grams for those of you that do NLP stuff. But it comes out of iKnow automatically, and you can see in the APIs, it gives you the frequency and the number of documents it was found on, and you can drill down to any one of those things like almost instantly really. So that's a really nice feature. So for, you know, and I have a bunch of slides here, and I just wanted to show you like, some of the different variations there are. A lot of times, you know, the notes aren't clean, and if you have templates and things like that, a lot of times you'll see things like numbers or whatever that just kind of float, you know, in midair. And so you can't just go by looking at the results all the time. You've got to sometimes look and see, was this part of the template? Sometimes you'd see like square brackets where it would be a checkbox. Anytime you go to the doctor, right, they hand you a form. What's your family history? What's this? What's that? Well, we do the same thing in the VA. So if you're just doing straight frequency counts of words, that's not good. You got to subtract that stuff out. So I have a slide I'll show you with some of that stuff in. These kind of variations are just, you know, more of the same, where you have, you know, this is where I needed a clinician. Actually, one of my doctor friends, we have a standing appointment on Thursday nights, and, you know, we tinker around with iKnow and we analyze notes. But I'll see stuff like this, left TKA, and I have no idea what that means. But, you know, he'll translate and say, oh, well, that means total knee, you know, arthroplasty or whatever. And so, you know, the coupling again between, you know, working with physicians and clinicians with an IT guy is really kind of evident when you start really working with this stuff. So I'm lucky because in the VA, you know, we've got 20,000 physicians and 7,000 IT people. So again, this is just more of the same. But I really just threw a lot of these slides in here just so you could see none of the text is clean and the misspellings and everything. But iKnow does a good job of showing that stuff. So if you want to drill down, it's really important. And I'm trying to get the VA to put this search technique inside every patient record. Everybody's heard of, you know, how hard it is to get appointments in the VA and how, you know, terrible, you know, everything is. And they actually put like 15 analysts to analyze the appointment wait times in the VA, right? All I have to do is ask a doctor, why does it take you so long to see a patient? Well, in the beginning of the talk, I told you, like, they can't find data. It takes them a long time to navigate whatever. a simple search like this would be a huge thing, right? You might be able to shave 4 or 5 minutes off just from giving them this kind of simple search capability. So that's another thing that, you know, if you show it to people enough times, you know, you hope that it catches and they'll start using it. But again, more of the same. All these abbreviations are just, you know, pretty incredible. I was thinking about building a dictionary just of abbreviations and, you know, ways that these guys have of doing stuff. So, okay, so what I like about it, it's fast. So when I index documents, I can index 100,000 documents on a single machine and it'll take like 15 minutes. It's pretty good. Thinking about doing it in real time is a possibility. It depends on the length of the document. So that's something that's potentially available. Everything that you see with iKnow is basically available with an API, so you can make a call. It's scalable. One thing about doing document analysis is if I wanted to use 5 machines, I could launch 5 different you know, queries or whatever you want to call them, processes for all 5 machines, and essentially get complete parallelization, right? Because each document is pretty much independent of another. So it's really kind of a scalable solution. And, you know, Cache has that ability of, you know, you can be trendy no matter what you're doing with Cache. Like, when I'm talking to NoSQL guys who like Mongo and all those other stuff, they're like, yeah, we're NoSQL. We have these unique structures called globals, and, you know, they're not relational. And when I talk to the people in the data warehouse thing that only do SQL, I said, oh yeah, well, MUMPS is, or, you know, Cache also is SQL too, right? So you can talk to either side of the house and, you know, kind of hope for camaraderie when you're doing that kind of stuff. The other thing too is whenever I had any trouble, you heard John Palladino talking about calling the Worldwide Response Center, and then having access to the design teams is always a big deal. So they didn't make me suffer for too long before somebody would help out. Because a lot of times, I mean, when do you find the most bugs? You know, the day of your demo or the day before your demo or whatever. And so I'd be panicky and I'd call these guys up, and they were always really helpful for doing that stuff. The other thing you can do is, you know, I said you can call stored procedures. So anything that you can do with ODBC or whatever, it's, you can essentially do, you know, through your application code or whatever, call some of these features, call the database engine and get that data back, and you're ready to rock and roll with this thing. I took a picture here just because, you know, I wanted to show you, to prove to you how efficient it is. 24-core machine, I'd launch the iKnow stuff, and every one of the processors would peg at almost 100%. I had to actually wait till it dropped down to 94% before I could actually snap the screen, right? So this is other stuff I'm just gonna skip over most of this stuff. A lot of things where I started having to write code where you'd see something like this where it would say patient's condition, and it would be multiple choice, like you have to check it off. So I started writing some parser routines that would go through and say, okay, I'd rewrite the text file as a sentence and just say the patient condition is improved. So there's a lot of things like that. And then you see things like this, my third example here. When did you get your last influenza vaccine? Well, the default in the VA template was never, but right underneath of it, it would say October 4th, 2011, right? So you know that they got it, but nobody changed the default. So there's a lot of interesting things that you got to do here. So, and I think with that, I'll probably stop. But these are all the intersystem software engineers, and basically, you don't see a lot of VA people on here because, like I said, you don't need a lot of developers or whatever to get started with this thing. Everybody's got unstructured data, and if you have Cache, it's already embedded in, you know, in the product itself. So, I mean, you can start using it just about any time. So, okay.
So, thank you very much.
Yep.
So,